take over the session. Welcome, sir.
Okay. Now, the next point is about the distributive shock and its management. Now, before going into the management of distributive shock, it's better to have an idea of the pituitary adrenal axis, which is one of the important mechanism of the body to maintain the homeostasis. So, most of the times, it's the other way, like whenever there is a shock, it's a failure of the pituitary adrenal axis mechanism, and management of the shock would be mainly through improving or maintenance of this pituitary adrenal axis with the pharmacological management. And hence I would think that I would consider this way, like considering this studying of this pituitary adrenal axis in brief. Now, I am not going into the detail of physiology. I will be just looking at the issue only from the point of view of the shock and its management, and a bit about that pituitary adrenal axis would be the one of the important issue. Now, as you know, the nervous system is the system which makes a person respond to the stimuli easily, immediately. But in the long term, the response to the stimuli would be done by the endocrine system. Endocrine and nervous system are the two systems which make the person, any living being, responsive to the environment, like any changes in the environment. For that, it could be any sort of that stimuli, a short duration stimuli or long duration stimuli. The suitable reaction to the stimuli would be done by the nervous system as well as the endocrine system. In the endocrine system, master of the endocrine gland is the hypothalamus, the pituitary. Pituitary would be having the stimulation. There again, you have the anterior and posterior pituitary. You know, from the anterior pituitary, the ACTH, adrenocorticotropic hormone, which stimulates the adrenal cortex, and the adrenal gland would be ready producing the enzymes or hormones which are responsible for the mechanism of maintenance of the body. Now, to be very brief, the hypothalamus or the anterior pituitary would be stimulated due to any of these stimuli, like simply the day and night changes, temperature changes, the spent energy in the body. Most important, all our focus would be stress, physical, emotional sorts of the stress, inflammation, and whenever there is need to tissue repair, these stimuli would be producing the stimulation to the pituitary, and the pituitary would be stimulating this adrenal cortex, and the adrenal cortex would have a regulation. The hormones of the adrenal would be having the regulation on the gluconeogenesis, lipid metabolism, growth of the body, and growth hormone as such. And it also, these hormones also have a property of reducing the inflammation and reducing the genes involved in the inflammation. As far as the stress is concerned, from the stress point of view, the management of the stress, the whenever there is a chronic stress, the chronic stress either it could be managed. The response to the chronic stress could be meaningful when the adrenal gland would be producing, adrenal medulla particularly, producing the hormones which are called as the steroids, and the cortex would be producing the hormones which you call as the catecholamines, and these would be producing the response. How that response would be produced, I will go into that. Now, the adrenal hormones would be, our adrenal gland is physiological. I am not going into very detail, like very brief as it is divided into the medulla, then the zona reticulata, zona fasciculata, and zona glomerulosa. The main important hormones which are secreted from the cortex, that's the zona glomerulosa and the cortex, would be the when the adrenocorticotropic hormone stimulates the adrenal gland, it produces the hormones which we call as the steroids, mineralocorticoids and aldosterone. Then the zona fasciculata mainly produces the corticoids which are called as the glucocorticoids. Glucocorticoids and mineralocorticoids are the two types of the steroid hormones. And along with that, the sex hormones like androgens, estrogen, and they also are produced by the zona fasciculata. To a certain extent, some amount of the mineralocorticoid also is secreted by the zona fasciculata. Then the medulla mainly produces the catecholamines, epinephrine, norepinephrine, and dopamine. These are the hormones secreted by them. Now, what we mean by these catecholamines and steroids are, steroids would have a basic structure. These three hexagonal, one pentagonal, and hydroxy molecule. This structure is called as steroid. Any substance derived from the sterol is called as steroids. Steroids word is not related to a single molecule. It could be a huge number of molecules which have a basic structure. Organic chemistry, those who have studied organic chemistry can make out that, and they are called as steroids. So steroid is not a single drug or a single molecule. Any molecule having a basic structure of sterol and derived from this, and then having many permutation and combinations of the other structures, they are called as the steroids. Whereas catechol is the substance where you have the hexagonal benzene ring and having two hydroxy molecule is a catechol, and any substance which is having an amine radical added to that would be catecholamines. Catecholamines are these two groups. Now, among the steroids, we'll now go into the steroids, the normal functions in brief, and then how it helps in the stress management or in the shock management. The steroids are mainly categorized into three categories: glucocorticoids, mineralocorticoids, and sex hormones. Sex hormones, of course, in the adult life, the major source of the sex hormones are from the genital organs like ovaries or testicles, whereas before the adult life, the main source of sex hormones is the uh, adrenal gland itself. And the sex hormones are androgen, progesterone, estrogen, which have a total different function and which we do not consider now when we discuss about the shock and stress management. So, sex hormones is just a casual reference to the adrenal functions as such. Whereas glucocorticoids and mineralocorticoids have a major role to play with the mechanism of maintenance of the stress or response to the stress, and have a role to play in case of the shock management. Now, glucocorticoids again are again two categories: cortisols and corticosteroids. When there is a corticosteroid group, then it's a steroids and otherwise cortisols. And average daily production in an adult is 5 to 30 milligram of cortisol and 2 to 5 milligram of the cortisone. And aldosterone is a mineralocorticoid. Now, the difference between mineralocorticoid and aldosterone, these glucocorticoids are, the mineralocorticoids would have a function of enhancing the sodium reabsorption and potassium and hydrogen excretion, and hence that will be resulting in accumulation of sodium and water. Because of the retention of sodium and water in the body, the total volume of the circulation increases under the mineralocorticoid effect. Whereas the glucocorticoid functions are, one the major function is it breaks down the protein and breaks down the glycogen. Hence, production of increased sugar level. Now, once the sugar level is increased and then there is a protein available for the metabolism, the energy production in the body would be higher, and because you have a better energy, you will be able to face the stress better. That's how it prepares the body to face the stress. So it provides more energy to the cells, and as the cells have more energy, they can face the stress better. Namurchati Anna Sanyoga, that's what Sushila has said. So Anna Sanyoga occurs even at that level, cellular level, due to the glucocorticoid effect. Then over the cardiovascular system, it makes the cardiovascular system more responsive to catecholamines. Catecholamine actions, epinephrine and their actions we will be discussing separately later. In general, the epinephrine or catecholamines would have a positive inotropic action. Positive inotropic action in the sense they enhance the total volume of the cardiac output. The minute cardiac output would be increased, as well as the rate of contraction would be increased. So they stimulate the heart to pump better. Then over the immune mechanism, primarily it suppresses the immune reactions, and hence the toxic complications where a tissue destruction can occur can be reduced. It prevents the tissue destruction as such. The plasma cortisol levels in the body, they are having a pattern of a time cycle. Like it's not secreted uniformly. The secretion of the cortisols are more in the early morning hours. Now, this is what is well known. At night, when you sleep, during the sleep, the level is very low, and early morning hours, the glucocorticoids are increase more, and then of course the secretion is level is physiologically the level is more. Then as the day passes through, depending upon the stress, there will be some increase or depression or increase as such, so you'll have some elevation or this depression of the cortisol levels in the body. And again at the evening hours, again it tends to reach, but the peak is always in the early morning hours. That's why early morning hours are considered to be better for any of the activity, including the study. So anyway, that early morning hours are the times where the cortisol levels are more, and hence the energy level would be more, body would be fresh, tissues would have a better capability to face the stress. That's the importance. Now, the glucocorticoids are mainly which now are available. It's about the commercially available. I'm just skipping many of those details to make it brief. So, from the current point of view, you will have many of the these steroids hormones which are artificially prepared, synthesized in the laboratory, and those synthetic substances which are available in the market and which are now used in the clinical practice regularly, they are either hydrocortisone or prednisolone, methylprednisolone or triamcinolone, or it could be dexamethasone. No, I think you have seen dexamethasone being used quite frequently in the ward, and the aldosterone and desoxycorticosterone. Aldosterone also you might have seen in many of the patients of cirrhosis being used as a these are certain of the substances which are now used in the clinical practice, which we call as steroids. Now, of course, what we use in the cirrhosis patients is a aldosterone antagonist. Aldactone is used, not aldosterone, but it has a relevance with the clinical practice of using in case of the cirrhosis-like conditions. Now, difference between these are the dexamethasone is the shortest acting drug. It's the long acting drug. The duration of the activity would be quite long. So longest acting is a dexamethasone. Whereas a hydrocortisone is very short acting. The effect is seen within a short period. Prednisolone and methylprednisolone are intermediary acting. That means the half life is around 6 hours. Half life of hydrocortisone is just 2 hours, and the production effect is immediate. With the dexamethasone, the half life is around 12 hours, so effect will be lasting for about 24 hours. Whereas betamethasone and triamcinolone are intermediate. Betamethasone is long acting and triamcinolone is intermediate acting. But more frequently, what we use is dexamethasone and hydrocortisone or prednisolone are more frequently used in the clinical practice. And from the point of view of glucocorticoid activity, the high potent is dexamethasone. Dexamethasone is a very potent, having the maximum glucocorticoid activity. Glucocorticoid activity we have already discussed in the previous session, this slide. Whereas comparatively, hydrocortisone is less potent. Prednisolone is somewhat more potent, so that's how the degree of potency is seen. And virtually the mineralocorticoid activity, that's retention of water and electrolytes, retention of water and sodium, that's maximum with aldosterone, and very little, moderately level at the prednisolone and methylprednisolone. Dexamethasone has the least effect of accumulating is accumulation of water and electrolytes in the body. So whenever you use steroids for a prolonged duration, any stress which involves, which requires a prolonged preparation of the body for the stress, then dexamethasone is preferred. If it is a short duration, then prednisolone is preferred or hydrocortisone is preferred. If there is a, like now, example would be in the patients who have cerebrovascular accident, and hence there is a tendency for going into the damage of the tissues, as well as there is a possibility of going into a shock condition. Dexamethasone is preferable. Whereas if the patient had some acute complication like toxicity, acute toxicity, or a patient who had these acute poisoning like conditions, then or a patient who has bled a lot and then there is a shock, patient doesn't recover from the shock, in that condition, hydrocortisone is preferable. That's how the drugs are preferred. Of course, aldosterone is not used in the stress usually unless there is a very specific indication. Now, steroids are used not only in the stress, they are used in many other conditions. In many other conditions, steroids have an indication. Again, a huge number of diseases, steroids are used, and particularly glucocorticoids are used. And I'm not going into all the details, but the quite important, frequent are, suppose the number one always would be a replacement. If there is a patient who has a deficit of the steroids in the body, either due to the adrenal insufficiency or due to a handling of the adrenal gland in surgery or during surgery, so on. So, whatever that adrenal insufficiency, where there is a need to cope up with the deficit, you may have to give the steroid as a supplement. The other two important conditions from our present issue point of view, septic shock, anaphylaxis, and stress intolerance. Septic shock is what we have already referred to. It's a shock of isovolumic, like or distributive shock, where the volume is not lost, better the body is not responding properly. Anaphylaxis, I will just go into that a bit more detail later after discussing about these distributive shock produced with inflammatory conditions. In general, anaphylaxis shock is a sort of allergic reaction where there is a reaction between an external substance and the body, and many of the intermediary products during that would be produced, which will produce a sudden vasodilatation. And it's also a distributive shock, which we will be discussing somewhat in detail. Stress intolerance is whenever there is a long-term duration of the stress, normal mechanisms of the body would be helping to cope up with the stress. If that stress, normal mechanisms are not able to cope up with the stress, either due to severe increased level of the stress, or it could be due to the reduced capacity of the pituitary adrenal axis, you need to supplement to the glucocorticoids. Then anti-inflammatory uses are hyperreactive pathologies like what autoimmune disorders. In rheumatoid pathologies like conditions where there is a progressive inflammation conditions, steroids are indicated. Pemphigus like conditions. Steroids also are used with the analgesia as an adjunct to the analgesia to potentiate the action of the analgesia, particularly during anesthesia. During anesthesia, to potentiate the action of anesthesia, steroids may be given as well as supplementing that. Of course, in daycare surgeries, like because the daycare surgery where the patient is not admitted in the hospital and the patient is not under observation, to ensure that the patient may not develop any complications later, a small dose of steroids are being given quite frequently. Then other indications like cerebral edema, spinal cord injury, or various surgical causes, it could be like. Now, steroid administration could be of mainly three categories based upon the dosage level, either low dose or medium dose or high dose. For all stressful conditions, acute stress or shock like conditions, it's usually high dose and short duration is preferred. Low dose and medium doses are preferred in case of a long duration treatment like anti-inflammatory conditions or even in case of autoimmune disorders. There again, there is in the low dose or medium dose, there are two mechanisms of administration. Either it could be a pulse therapy or it could be a prolonged maintenance therapy. Pulse therapy is a short duration of high dose, then gradually taper to a moderate dose and maintained at the optimum level. Usually, as in case of nephrotic syndrome, pemphigus-like conditions where the patient presents with an acute presentation and the ones that has to be suppressed, that acute presentation of the disease need to be suppressed, then you give a high dose of steroids for a short duration, and once it has reached to a stable level, you maintain that level. Or in case of chronic diseases like rheumatoid pathology, a low dose throughout is maintained. You don't need to go for the pulse therapy. Whereas high dose is reserved for acute shock conditions where you need to have a immediate response. Then usually the category this duration based upon the duration, a treatment of less than 1 month is considered short term, and treatment for more than 3 months is usually long term. This is the usual terms used, and whereas given for a few days or a short less than 3 weeks is what we consider as a safe duration. But the need for this classification short term and long term is when the steroids are withdrawn. During the withdrawal of the steroids, one of the basic issues of the steroids would be, or rather any of the hormones would be, whenever you administer any of the hormones from an external source, the normal hormone secretion of the body would be suppressed because of the negative feedback mechanism. Now, if at all you withdraw the hormones suddenly, then the initial secretion of the hormones in the body would be totally compromised. They will not be able to cope up with the requirement, and hence all the hormones need to be tapered once they have been administered for a duration during which the your inherent this basic hormonal secretion of the body is suppressed. Whenever there is a long-term treatment of steroid administration, this tapering is absolutely essential. And short term, though it's often said less than 1 month, practically we use 3 weeks. If the steroids are given for 3 weeks, then it needs to be tapered with a short gap tapering. Whereas if it is given for a 3 months long duration, it has to be a long gap tapering. Whereas the given for a short duration like a week or so, you don't require tapering. This is how the requirement of this. When I say short gap tapering and long gap tapering is in the short gap tapering, you reduce the dosage by half by every 2 days. Whereas long gap is you reduce the dosage by half every 1 week. Like suppose the patient is on 20 milligrams steroids and it is given for only a short duration like 3 weeks or 1 month, then you reduce it. Once you have to reduce the dosage, you give 10 milligram for 2 days, 5 milligram for next 2 days, and then so on. Whereas if it is given for a long duration like 3 months, then it has to be 20 milligram to 10 milligram for 1 week, then 10 to 5 milligram another 1 week, and so on. So this way, that's what I mean by the short duration tapering and long gap tapering. Now, anyway, that's the importance of the dosage and the usual issues. Then the low dosage is usually for replacement therapy. As I said, some of the examples like Addison's disease or hypopituitarism and so on, where the dosage is decided by the basic condition of the body. Then there is a universal dosage for long-term therapy as the pulse therapy, where like rheumatoid, lymphoma, etc., it's gradually decreased, given in a high dose and then gradually decreased. Then high dose or impulsive therapy or pulse therapy, where serious infections is given in very high dose, and in shock-like conditions, as I said, a short-acting drug like hydrocortisone, it can be enhanced. The dosage could be very high, up to 4 to 6 grams per day. In a typical shock, the upper limit of the dosage would be till the patient responds. And when I say till the patient responds, the total dose could be very high, up to 4 to 6 grams per day. Not that every patient is given 4 to 6 grams. You usually start with the 250 milligram, then if necessary you increase by 5, increase to 500 or so on, and the maximum per day could be 4 to 6 grams per day in case of the shock. So in case of the shock conditions, the dosage given is very high until the patient recovers. Once the patient recovers and he is able to maintain his physical conditions by himself, then you don't need steroids. There is no question of tapering there in case of the treatment of these steroids in shock conditions. Whereas in other conditions, that whether you need to taper the doses or whether you can abruptly stop the doses depends upon the duration of the treatment. Now that's the issue is about the same issue which we have discussed, tapering of the doses. is, as I have told already, the same issue is seen there. Now, adverse effects of the steroids. The steroids are well known to produce adverse effects, and the commonly used terms are a moon shape and buffalo hump. If steroids administered for a long duration, they will produce a change in the body in a such a way that the face would be, there will be accumulation of the fat in some areas, core part of the body, and hence the abdomen and chest area that becomes prominent. Face becomes roundish, and that's why it's called as moon face, and the periphery would be relatively thinner. In addition to that, the steroids can produce various complications, right? And those could be the hairs could be thinned, or it could be psychosis could be produced. It can induce cataract. It can produce acne. It can, that's moon face. It can induce a peptic ulcer. It can increase the blood pressure, and it can also produce a osteoporosis, and the growth of the bone could be affected, which can result in fractures also. Menstrual abnormalities and impaired sexual functions also could occur, and there could be obesity, and skin thickness would be reduced and producing a typical shining skin with the rugae as such. Then wasting of the periphery, even there could be tendency for infections. Wound healing would be affected due to the steroids. That's about in brief about the steroids. Now, in case of a distributive shock, to make the patient respond to the treatment, steroids are given, and what I said is the dosage would be based upon the response of the patient. The maximum peak dose could be 4 to 6 grams. Whether you prefer a short-acting drug or long-acting drug would be depending upon the condition of the patient. If the patient needs an immediate response, you give a short-acting like hydrocortisone. If it is the patient's otherwise he is stable, it's not that the response should be immediate, but you want to maintain the patient's condition for a longer duration. Dexamethasone is a preferred. That's what we most of the times in our clinical practice in the patients like cerebrovascular accident, cerebral edema-like conditions, we prefer long-acting drug like dexamethasone. Suppose the patient had a shock in the operating room, and there was some toxic substance was injected, and somehow the patient had toxicity. In that condition, hydrocortisone should be preferred. So that's about the steroids in brief. I will not go into more detail. The next part is about the catecholamines. At the end, I will be dealing with how they are planned in case of the management of shock. Now, catecholamines, among the catecholamines, the most important is epinephrine or adrenaline, and then noradrenaline. Synthesis of the epinephrine or noradrenaline would be from the tyrosine. Tyrosine is one of the amino acids, essential amino acids in the body, and tyrosine is converted into deoxyphenylalanine. So alanine to tyrosine, tyrosine to dopa, and then you have dopamine. Dopamine is one of the intermediary precursor to the adrenaline. Now, this synthesis occurs in the nerve endings. Nerve endings, the alanine would be converted in tyrosine, tyrosine to deoxyphenylalanine, and phenylalanine to dopamine. Now, from the clinical point of view, this level, dopamine is important. Dopamine will be present in the the cytoplasm of the nerve cell. Then dopamine will be taken up into a vacuole, and in the vacuole it can be collected, and it will be converted into adrenaline or epinephrine, and the epinephrine also is converted into norepinephrine as such. Whenever there is a stimulus in the nerve endings, particularly what we call as the adrenergic nerve endings, uh, these sympathetic nerve endings, whenever there is a stimulus, it's released into the synapse and produces its effect on the whatever the target organ. I will come to that, like which are the target organs and what are the effects. Now, one of the important issue is these adrenaline and noradrenaline, which is secreted into the synapse and produces effect. A major portion of that would be reabsorbed. There will be uptake, and this is what calls the uptake one. It takes up into the the cytoplasm. From the cytoplasm, again it reaches to the vacuoles again back. So it is what called as a uptake two. Now, adrenaline and noradrenaline, the catecholamines which are secreted, more major portion, about 70% of that, would be reabsorbed into the cell and it will be reutilized. Only a small portion of that, which is present in the circulation, will be metabolized by the is catechol O methyl transferase, COMT, catechol O methyl transferase enzymes, and it will be excreted in the urine. That end product is excreted in the urine as such. So the important issue is the adrenaline and noradrenaline are reabsorbed, and the reabsorption would be having two stages: uptake one stage and uptake two stage. Of course, from the point of view of pharmacology, these are important because you have some drugs which can either block this uptake 1 or uptake 2. If the uptake 1 is blocked, then the duration of adrenaline present in the synapse would be more, and hence it also acts as an adrenergic activity. The adrenergic activity would be enhanced. Uptake 2 would be also can be blocked, and in that condition, the quantity of the, the adrenaline in consequent impulses would be lesser. See, first impulse, whatever that present adrenaline is present in, would be released into the synapse. For the consequent impulses, for the adrenaline to be secreted into the synapse, you need the adrenaline getting back into the vacuole. Now, uptake 2 is if it is blocked, then the amount of adrenaline secreted in the next stimulus would be lesser, and hence in the long duration, a uptake 2 blocking drug can act as an anti-adrenergic drug or adrenaline antagonistic drug. These are from the pharmacology of a sympathetic nervous system, and I will not go into that detail now. We will be dealing with only the role of catecholamines in the shock. Only one aspect of the pharmacology are discussed now in the present session, whereas the detailed pharmacology would be having all the other repercussions. Now, the effects of adrenergic nerve, sympathetic nervous system, of course, sympathetic nervous system is the major mechanism by which the adrenaline is secreted. A significant amount of the adrenaline also is secreted by the adrenal medulla directly into the circulation, and hence it will also have a generalized effect. But when the action is through the sympathetic nerves, the effect would be of specific at the target area, and those targets are over the eyes. It produces relaxation of the radial muscles, and hence there will be a mydriasis. We call as active mydriasis. Active mydriasis because the ciliary muscles, radial muscles of the eye, ciliary muscles, they would be contracted, and because they become contracted, the opening of the iris will be widened, and hence it's a active mydriasis. uh, Whereas in the other way, circular muscles will be contracted, and yeah, that's it. Circular muscles will be not affected. Radial muscles will be contracted. That results in active mydriasis under the sympathetic stimulation. Over the parotid gland, it enhances the mucin secretion, whereas the water content of the saliva would be lesser. That's why during the stress you will have a feeling like the tongue becomes sticky. You will have a dry mouth like conditions at the time of examination, a perimeter examination. You feel like having a sticky mouth, and you feel like taking more water because of the stress. And over the heart, it stimulates the heart contractions. It enhances the activity of SA node, as well as enhances the activity of the conducting systems, Purkinje fibers also, and hence there will be a tachycardia. It becomes hyperactive. The refractory period is shortened, and hence the whole muscles they become more active. Over the bronchi, the adrenergic system, when the epinephrine is secreted in the adrenergic nerves, it produces the dilatation of the bronchi, and hence resistance of the airways would be lesser. So more air can flow with the same effort of breathing as otherwise. Over the stomach, it enhances the secretion of the acid, as well as it enhances the time taken for the gastric emptying. Gastric emptying period is prolonged. The sphincters become closed and the food remains in the stomach for a longer duration, and hence it will have an impact upon the acid secretion. The gastric phase of the acid secretion will be enhanced. Over the kidneys, the adrenaline would be increasing the circulation into the nephrons, and hence the total amount of the filtration occurring in the kidney also would be enhanced. Though there may not be a diuresis, at the end there may not be diuresis, but the vessels would be dilated and the amount of the fluid which is reaching to the kidney would be more. Over the intestines, large intestines, it reduces the blood flow to the intestines, and it slows down. The peristalsis slows down acid. Over the bladder, the adrenergic system, it makes the bladder irritable or more contractile, and hence there will be increased secretion of the urine, or frequency of the micturition is increased. Over the peripheral blood vessels, it has a dual action based upon the presence of the receptors. There are two types of adrenergic receptors, alpha receptors and beta receptors. Alpha receptors are mainly over the peripheral blood vessels, and in the peripheral blood vessels, it produces constriction. Over the beta receptors, it produces dilatation. So, there will be a preferential either contraction or this dilatation of the blood vessels. Whenever there is a stress, the stress needs more blood to the vital centers like the brain, lungs, and the kidney, and hence the blood flow to the brain, lungs, and the kidney has to be enhanced at the cost of a relatively less essential organs like the skin and the gastrointestinal tract. So you will have more alpha receptors over the blood vessels of the skin and the gastrointestinal tract, and more of the beta receptors in the vessels reaching to the brain, kidney, and heart. And hence, whenever there is a adrenaline secretion, the blood flow to the periphery would be reduced, or the skin, the vessels of the skin will be constricted because of the alpha activity, whereas the blood flow to the kidney and brain would be enhanced due to the beta activity. This is how the body is prepared to face the stress and produce a response. Now, adrenal medulla, it produces again the same, the adrenaline, epinephrine, directly into the circulation. See, that's the difference between the adrenergic nervous system and the adrenal medulla is in the adrenergic nervous system, the adrenaline is secreted at the specific target organ. When there is a need to produce this effect on the eye only the effect would be seen when the optic nerve, the adrenergic nerve fibers in the optic nerve are stimulated. Whereas you may not have the same action throughout. Whereas when the adrenaline is secreted from the medulla, because it is the adrenaline is secreted throughout the body in the blood, every organ would have that adrenergic activity, and hence you will see the changes throughout. Now, a effect which you see when you go for stress-like conditions in the exam, when you go into the exam period, you will have palpitation, you will have a reddish face, the blood flow to the face will be enhanced, whereas you will feel like having some this tingling sensation in the periphery because reduced blood flow to the skin, and the urinary output may seem to be increased. You feel like going for micturition and so on. You will have the palpitation due to the increased rate of the heart contractions, and most of the times you will have a constipation during the examination, like because of the reduced intestinal motility, your appetite may be reduced. So these are all due to the adrenaline secreted from the medulla into the system. You will have a multi-systemic effect. And the effects, as I again summarized, some more would be like in addition to those which we have discussed, the others are in the eyes, I have already told mydriasis would occur. Over the uterus, it produces a contraction. Over the skin, it stimulates the sweat glands, and hence there will be more sweat also. And the platelet aggregation would be enhanced. The clotting would become more acid. In the male, it also enhances the ejaculation, bladder contraction would occur, and there is a tendency for hyperkalemia. The potassium level tends to increases acid, and then as I told about the nerve fibers, there are two types of the receptors, alpha receptors. These are all the effect of the alpha receptors, stimulatory effect of the alpha, whereas the beta receptors are, in general, they are stimulatory and they are responsible for the effects which you see in case of tachycardia, increased myocardial activity, increased breakdown of the fat, and the renin release. Renin is a enzyme which is present in the kidneys. Then, to make it more complicated, I think we will not go into that part now, but still it's an essential. Among the beta receptors, you have certain more categories, beta 2 and the beta 3 type of the receptors. Beta 2 type of receptors, though the general rule is beta receptors are stimulatory, beta 2 could be relaxing, or they may produce inhibitory activity, and over the bronchi, it's mainly the beta 2 receptors which produce the relaxation, and the skeletal muscles, vessels, also there will be dilatation, and there will be these uterus tends to produce relaxation, and glycogenolysis would occur. Now, that importance of beta 1 and beta 2 are important from the pharmacology of the adrenergic nervous system in detail. Say, from the present point of view, I will not go into that detail. If at all there is a need, we can discuss that maybe in the later some sessions in specifically. So, for the present, I will be very brief about this activity. Now, the same, the total metabolism, as I already have referred to that, the metabolism of this would be once that adrenaline or noradrenaline is secreted in the body, it will be utilized by the organs, and at the end, it will be converted into vinyl mandelic acid and excreted in the urine. Now, from the clinical point of view, important is the assessment of vinyl mandelic acid in the urine can be a criteria of assessing the levels of the adrenaline secreted in the body. Now, adrenaline or noradrenaline, epinephrine or adrenaline are synonyms. You may use any of the words. They are metabolized by two sorts of the enzymes, one monoamine oxidase enzyme and catechol-O-methyl transferase enzymes. Catechol-O-methyl transferase is COMT, monoamine oxidase MAO. Now, these are the two enzymes which are responsible for the metabolism of adrenaline. Impairment of these hormones, these enzymes, also would be affecting the adrenergic activity of the body. So that's from the clinical point of view, where the patient may have a hypersteroidism or hyposteroidism and so on. So from the stress point of view, these are not very important. Now, clinical uses, mainly the adrenaline. Adrenaline is often considered as a drug of choice, or epinephrine is considered as a drug of choice in the case of anaphylactic shock conditions, because it produces the constriction of the blood vessels selectively. Blood vessels to the periphery would be constricted, blood vessels to the vital organs would be dilated, and hence it maintains the vital circulation, essential circulation, and hence it is considered to be a drug of choice in case of the anaphylaxis. And the usual dose is zero point 0.3 to zero point 0.4 milligram per second, or 1 is to 1000 solution. In a dilute solution, it has to be given. Epinephrine also is used in case of cardiac arrest, acute cardiac arrest conditions, to stimulate the heart. It's used there. Then it's often mixed with the local anesthetic. Now, we have seen in the OT, you may have a plain lignocaine or lignocaine with adrenaline. That adrenaline mixed with the lignocaine would produce a constriction of the blood vessels at the site of injection, and hence the duration of the anesthetic activity can be prolonged. A plain lignocaine can produce anesthetic activity around 30 to 40 minutes, whereas the lignocaine with adrenaline, the duration can be enhanced up to 1.5 hours. So that's the advantage of the lignocaine with adrenaline or plain adrenaline. So that's another way, but there it's given subcutaneously. Whereas for anaphylactic shock, it can be given intravenously or subcutaneously. Adrenaline is preferably intravenous or subcutaneous. For cardiac arrest, it has to be given intravenously or maybe intracardiac. Then, over the surface of the body, topical uses, if there is a bleeding, to stop the bleeding, adrenaline pack is used, particularly nasal bleeding. In hyperkinetic children, where there is an abnormality of attention and so on, In such conditions, it could be a small dose of adrenaline could be given. And to reduce the increase the appetite as an anorectic, to reduce the appetite, adrenergic drugs are used. And same as I told you, it's the dosage in case of cardiac arrest 1 milligram. High dose is given, whereas it also precautions, particularly when you give it by intravenous route, is important is that it can produce a myocardial ischemia, and it should not mix with the alkaline solutions, and it can even produce ectopic beads. That's about the important. From the clinical point of view, in addition to the adrenaline or ephedrine, you will have many of these adrenergic agonists or drugs which will have adrenergic like activity, adrenaline like activity, and of course, I think that would be more important when we discuss about the pharmacology of adrenaline. From the shock management point of view, the only ephedrine is one of the drug which is of some significance. Others may not, and isopretinol would be another of the drug which could have some importance. Others, they are having a different pharmacological activity, so we will not go into that part now. This also we will just skip for that. Now, in case of the shock, the adrenergic drugs are used to have a vasopressor action. See, after all, in case of distributive shock, it is about the dilatation of the vessels, and in case of the dilatation of the vessels, you need to make the vessels constricted, and hence the vasopressor action is preferred. Among those different varieties of the adrenergic drugs, the drug substances which can have a potential vasopressor action. I have left that part. I have not gone into the detail about different other varieties of the adrenergic derivatives. I am just referring to those adrenergic derivatives which are used in the management of the shock, and their activity would be the epinephrine is the broad acting which will act on both alpha and beta receptors, and hence it produces a vasoconstriction as well as a stimulation of the heart inotropy, and it's hence it's a drug of choice in case of the anaphylaxis, asthma or cardiac arrest induced conditions. And of course, this column is not important. And norepinephrine, because it produces mainly vasoconstriction and doesn't have any effect on the respiratory tract, is mainly used in the septic shock conditions. Septic shock, noradrenaline is preferred. Phenylephrine is also having vasoconstriction, and in usually phenylephrine is supplemented for the adrenaline. Suppose adrenaline is given, and the adrenaline is a very short-acting drug. It increases the pressure immediately, but again there could be hypotension. In such conditions of hypotension, for a supporting, which we call as a push dose, is given. Dalbutamine is not very popular, but it's a drug of choice in case of cardiogenic activity because of a positive inotropic action. Then the dopamine. Dopamine will have a dual action. In the, of course, I will come to that part again in detail. In the very small doses, very minute doses, dopamine would act as a vasodilatory drug, whereas in the later period it produces a vasoconstriction, and it can produce the blood pressure changes within a short period, and it's ultra short acting, and hence for maintenance of the blood pressure dopamine is usually preferred. The other two, the vasopressin and milrinone, they are not frequently used, but occasionally in rare conditions it may be used as such. Then methamphetamine is another of the drug which is quite frequently used in our clinical practice. In our OT, we use methamphetamine particularly in spinal anesthesia induced distributive shock. Spinal anesthesia also can produce a distributive shock like condition. The advantage of methamphetamine is a synthetic derivative of adrenaline. It has a relatively prolonged activity. It enhances the blood pressure, and the total raise in the blood pressure is comparatively smooth. Unlike that of adrenaline, it doesn't increase the blood pressure immediately, and it enhances the duration. It has enhanced duration of activity like around 1 hour. So for about 1 hour, it maintains the circulatory pressure, and that's why in such conditions is preferred. That's the methamphetamine as such. Of course, the same issue. Ephedrine, we'll discuss about the ephedrine later on as such. Now, in case of the shock conditions, the preferred drugs are If there is already a cardiac failure and you need to stimulate the heart immediately, then dobutamine is used, which is a rare condition. We do not use it in our clinical conditions. Whereas the other conditions, dopamine in a low dose can produce a stimulatory activity at 5 to 10 micrograms per kilogram per minute. Dopamine is mainly used as a cardiac stimulant, but doesn't produce a vasoconstriction to the same extent. Whereas the same dopamine is given at more than 10 microgram per kilogram per minute, then it produces vasoconstriction, increases the blood pressure. So advantage of dopamine is suppose a patient has a cardiac involvement, but blood pressure is somewhat maintained with other drugs, then low dose of dopamine can give a positive inotropic action. If the blood pressure also is lower in such patient, a high dose of dopamine has to be given, and its rate of infusion is the deciding factor. When you give dopamine, it is very important to assess the patient regularly, and the rate of infusion has to be corrected properly. If the rate of infusion is not corrected properly, then the dopamine can be harmful. So that's why if you administer dopamine to a patient, you have to keep the patient under continuous observation, and depending upon the blood pressure, rate of infusion has to be reduced or increased, and that rate of infusion is the critical criteria. That's why in clinical practice, I do not use dopamine regularly. Very rarely we use dopamine in my clinical practice because it needs a continuous monitoring. If you have that facility of continuous monitoring, dopamine is preferred. Without monitoring, dopamine is risky. Then adrenaline, of course, it's usually low dose is given for inotropic action. For a vasoconstriction activity, it's usually 0.21 to 0.42 micrograms per kilogram body weight is given. Norepinephrine is still lower dose of 0.02 to 0.025 micrograms per kilogram per minute is the usual dose. And the other vasodilatory activity. Now, this is another issue. In very low doses, dopamine would have a vasodilatory activity. Now, vasodilatory activity would be required in case of a distributed shock. Suppose a patient has a this shock and you have given the drugs, but blood pressure is maintained, but the peripheral circulation has not been recovered. There is a possibility that there could be persistent vasoconstriction, and due to the drug which is given, you will have to give a vasodilator drug. It's a rare situation, not frequent, and in that condition, a dopamine in very low, like 1 to 4 micrograms per kilogram per minute can be given to produce a vasodilator activity. That's in summary about the distributive shock produced due to other conditions. Next would be anaphylaxis, which we'll discuss in the next session. If there are any questions, I'll try to answer. Then we'll conclude today. Hmm? Right, there are no questions. So we'll conclude today. Thank you.